Another long topic, ankle and hindfoot fractures. Fractures around the ankle and the hindfoot. That is fracture of the talus, calcaneum, and the distal part of the tibia, the bones forming the ankle joint. Let's move on. Okay, sorry. Alright. So we have set some certain objectives: anatomy, fracture classifications, what are the common fractures, and how do we actually manage them. These are our learning objectives for today. Coming to the anatomy, this ankle joint is formed by the distal part of the tibia and fibula and the talus. There are ligaments. This joint is stabilized by the ligaments that are mostly on the medial side and the lateral side. The medial side is the ligament is also known as a deltoid ligament. It has the different parts. The superficial talotibial ligament. All three bones on the medial side, they have attachment with the medial aspect of the distal tibia. This is the medial malleolus. So this is the superficial talotibial ligament. Naviculum, this is the navicular bone, naviculotibial, and this is the calcaneotibial. Okay, this is the superficial part, and this is the deep part. This is the deep, which is not accessible easily. This is the medial malleolus, and this is the talus. So this is the deep MCL, medial collateral ligament. Okay. Coming to the lateral side, there are three ligaments on the lateral side: anterior talofibular, this one, which is the commonest ligament that injures with the ankle sprain. When the ankle gets twisted, this is the most common ligament that injures. Posterior talofibular ligament right here, and the calcaneofibular ligament. Okay, this calcaneofibular is the second most common ligament that injures in the ankle sprain. Syndesmotic ligaments. Syndesmosis. What is it? It is a joint. We call it another joint between the tibia and the fibula. It is stabilized by the four ligaments. Okay. Anteriorly there is antero-inferior tibio-fibular ligament. Okay, antero-inferior. This is the posterior-inferior tibio-fibular ligament, and intertransverse ligament. This is the intertransverse ligament, just below the posterior-inferior ligament, which lies transversely, and this the introssus tibio-fibular introssus ligament. So these four ligaments, they form the syndesmosis, also known as high ankle sprain. When this get injured, then we call it high ankle sprain. So it is the twisting injury that injures the ankle most commonly, and other mechanism is the road traffic accidents, when there is a direct impact or run over injury. These are we get injured. When there is a gross fracture, we get the deformity like this, or sometimes in dislocation, either medial or lateral dislocation. There should be fracture for the ankle to be dislocated, medial or lateral. Anterior posterior, there could be isolated dislocation without any fractures. Okay, this is the typical clinical picture which we see in the high energy ankle injury. Okay, we call it low energy, which occurs with the simple twisting mechanism, and where only the lateral ligaments are injured, or sometimes we see the lateral malleolus fracture. And in this typical picture, this is the gross swelling, ecchymosis. These ecchymosis, these are suggestive of the high injury. There's a huge collection over there. And this is the typical picture we see in the open fractures, like say open dislocation. This is the X-ray. While examining, we follow the protocol as look. In orthopedics, we follow look, feel, move. Okay, look is like inspection, what we see on examining. Feel is palpation, the swelling, tenderness. We examine tenderness in the middle malleus, lateral malleus, the base of the fifth metatarsal, and the high ankle sprain area, syndesmotic area. These are the area where we palpate, and we should not forget the distal neurovascular examination, the examination of the dorsalis pedis artery right here and posterior tibial artery right here, and knob, superficial peroneal knob that supplies the dorsum of the foot, and deep peroneal knob that supplies the first wave space. Okay, the plantar, the medial and plantar knob that supplies the sole. So we should not forget to examine the neurovascular status of the bone, the limb distally. Okay. Ottawa ankle rules. What are these? In Ottawa has given some criteria. Said who all needs X-ray. All ankle injuries does not require X-ray. They have mentioned is 55 or older, inability to weight bear immediately after injury, or if one cannot take 4 steps in the emergency. Okay, 4 steps, and bony tenderness over the lateral malleus, distal 6 centimeter of the lateral and the medial malleus, or the base of the fifth metatarsal. If this meets the criteria, then only we should proceed with the X-ray. It has sensitivity of 100%, specificity of 40%. So what are the X-ray views we do for the ankle injuries? AP, Mortise view, anteroposterior view, Mortise view, and lateral view. Okay. So what is anteroposterior view? Anteroposteriorly, we project the beam from anterior to posterior, and the typical structure we see is the distal part of the tibia, the medial malleus, the joint line, the dome of the talus, and the lateral malleolus. This is the incisural space, or we also call tibiofibular clear space. Okay, and there is some overlap of the distal tibia right here over the fibula, and this is the tibiofibular overlap. Okay, we'll come to this. As we can see in this picture, this this is not actually required in depth. As I was mentioning, tibiofibular clear space, we can see here the orientation of tibia and fibula. Fibula lies little bit posteriorly in compared to the tibia. So there is this is the anterior surface of the posterior surface of the tibia. This is the anterior. So there is some space there. This is the clear space, and this is the overlap right here. B and C is the overlap, and this A and B is the clear space. Okay, we can, if there is a medial collateral ligament injury also, then we can see the talus to be tilted. Ideally, this should be parallel. The distal plafond of the tibia, we call it plafond. Okay, plafond or pylon, and the dome of the talus, it should be parallel. The clear space, medial, this is the space between the talus and the medial malleus, and this actually this clear space in total we see in the Mortise view. Okay, it's the same thing. So in this picture, what we can see is that there is some fracture in the lateral malleus. This the blue line, it suggests it shows the tibiofibular clear space, and the yellow line, this is the overlap, tibiofibular overlap. If this blue line increases, the ideal normal value is less than 5 mm tibiofibular clear space. If this space increases, this suggests there is injury of the syndesmotic ligament that lies quite over here. Okay. If this increases indirectly, means this yellow line, the overlap should decrease. There will be diastasis. Then the tibia and fibula, they move apart. So the overlap will decrease and the clear space will increase. Okay. But in this X-ray, there is no evidence of. So Mortise view, We do it in around 10 to 15 degree of internal rotation of the leg. We rotate the leg itself. It's not the commonly the X-ray technician, they do the internal rotation of the foot only. So the X-ray doesn't come proper view. So this is the mortise view of the ankle, in which we can see the whole mortise, the medial clear space, the superior clear space, and the lateral clear space. These should be 4 millimeter. If it is more than 4 millimeter, like in this view, it suggests there is tear of the middle collateral ligament. And talar tilt. Actually, this talar tilt is done as a stress view. When we stress the joint in, like in the medially, the varus or valgus stress, if we give, then if we see the tilting of the talus, tilting of the talar dome in compared to the distal plafond of the tibia, this is, we call it talar tilt, up to 1.5 degree, positive or negative is normal. But it's if more than that, there is a talar tilt significant, and it suggests some ligament injury. In lateral view, we see the fibula and fibula right here, the tibia ankle joint, dome of the talus, the mortise of the ankle, talus, calcaneum. This any bone chip fracture, especially this view suggests posterior malleolus fracture, which we occasionally see right over here. Okay, this is the lateral view, true lateral view. Okay, and occasionally we need some oblique views also. In the earlier days when we didn't have CT scan and we had to plan for surgery, then we should go for the oblique views to better define the fractures. So how do we define stable and unstable ankle? Ankle as such is a ring. It's like a ring. Okay, it is stabilized. The ankle joint stabilized medially by the MCL, talus, bone, calcaneum, and the lateral collateral ligament and the distal pylon of the distal tibia. It is like a ring. When there is a disruption at any two space, any two point, then we call it unstable. Suppose there is only middle collateral ligament tear here and the lateral malleolus fracture, then that is also unstable, and that this we need to stabilize. Okay, only one fracture or ligament tear is a stable injury. So Lauge-Hansen, they has a classified ankle injuries based on the position of the foot at the time of the injury and the direction of the force which moved the foot. Okay, broadly it has been classified into different 15 types and 5 major categories, but we may not in this level, in your level, in MBBS level, you may not need in this depth. It depends on whether the foot is supinated or pronated, and this supinated, when with supinated foot, the external rotation force or adduction force. In adduction force, the lateral malleolus fractures, and at the horizontal level, the fracture is transverse. Whereas the rotating talus, it hits the middle malleus with the vertical fracture. Okay, but in external rotated with the supinated force and external rotation force, the lateral malleolus fractures with the typical oblique or spiral pattern. Then the posterior malleolus, there might be posterior malleolus fracture, and the transverse fracture with the more progressive force. Ultimately, the medial malleolus also may fracture. This is the typical supination external rotation injury. This is the commonest ankle injury pattern we see of the both malleolar fracture, medial and lateral. Similarly, the pronated foot, there is the external rotation force and the adduction force. These are the different fracture patterns we see with the progressive severe injury. Okay. So Dennis and Weber, both combinedly, they have given a simple classification of the fracture of the lateral malleolus based on the level of the fracture. Okay, this is Weber type A, below the syndesmotic ligament. This syndesmosis is typically around the 5 centimeter of the from the ankle joint. Okay, it lies. So if it, below the ankle joint level, we call it Weber A, and it is a stable type of fracture. We may go for conservative treatment with this. Weber B, there is at the level of the syndesmosis, and there is some injury of the syndesmosis, and if there is associated injury on the other side also, we need to fix it, or we may, after the stress test, when we sometimes do with the hook or with the help of towel clip, we pull it, this lateral malleus, and we see in the C-arm, in the operation theater, we check clinically whether there is a diastasis that suggesting the disruption of the syndesmotic ligament, and this needs fixation. And where we see it is high up above the joint, there is with the rotational force. So with the rotational force, this if there is fracture, this suggests there is a disruption of the syndesmotic ligament. So we need to fix this particular type C fracture. Okay. So let's come to the different X-ray, different cases. Okay. In this X-ray, look at the X-ray. Do you all see this? Any injury, any fracture there? Yeah, we can appreciate some in the lateral view. There is some fracture line, might be or not. It almost looks like normal X-ray. This is the os trigonum. Okay, sometimes this talus, it during the development process, it different ossific nucleus which fails to fuse with the talus, and it presents as a separate entity. So this is not a fracture. Okay. The same patient, this is the lateral view, and in AP view, see, there is some fracture of the lateral malleus below the level of the ankle joint, below the syndesmosis. So this is, see, in this Mortise view, almost this is the Mortise view done, not so clear much. We cannot much appreciate the X-ray, but in the AP view, you can see there is a fracture. Okay. So these are amenable to slab and conservative management. It does not require any fixation. So we have already dealt with this Dennis Weber A. So coming to this picture, in the lateral view, we can see the typical oblique, long oblique or spiral fracture, and there is some fracture in the posterior malleolus also. You can see here, right here. And there is a gap in the medial side. There is talar tilt. Okay, there is significant injury on the medial side, posterior side, and the lateral malleus. So this is like trimalleolar, or there's an injury at the 3 places. So this is a big or bimalleolar. Coming to bimalleolar, let's say, though this picture is suggestive of posterior malleolus and the lateral malleolus. Generally, we call bimalleolar when there is middle malleolus and lateral malleolus fracture. But here there is a posterior malleolus and the lateral malleolus. Okay. Bimalleolar, the injury at the 2 places is highly unstable, so we need to fix it operatively. Medial Mortise view, why this suggests instability. So immediately in the emergency, we give a slab, immobilize, and we wait till the swelling gets subsides, and then we fix it operatively. Okay, let's see this X-ray. And though the X-ray focuses a little bit high up, there is a large injury. It's a high velocity, looks like a high velocity injury. There is a fracture in the middle malleolus, there's a lateral malleolus, and this is a posterior malleolus. Okay, this is the trimalleolar fracture. These are unstable multiple ligamentous injuries. Usually they involve the syndesmosis, so a slab, urgent evaluation for the, sometimes there is a huge swelling, and there is a risk of compartment syndrome also. So we need to close monitor this type of large high velocity injuries with large significant bony fractures. So we fixed Orif. Orif is an open reduction and internal fixation. Okay, open reduction We have to open it, reduce it, and fix it internally. Okay, so open, reduction, internal fixation after the swelling subsides. Okay, this sorry, this X-ray, it has a fracture in the medial malleolus right here, fracture of the distal tibia. It's a very comminuted, very bad fracture, and the fracture in the lateral malleolus. A similar picture, fracture in the lateral malleolus high up, distal tibia fracture, medial malleolus is not clear here. So this is the typical X-ray of the tibial pylon or plafond. Okay, distal part of the tibia that has it has collapsed as such like this. So what is the mechanism? Generally, when there is axial loading at the ankle, either in the dorsiflex foot right here or the plantar flexed. When there is high velocity in the axial, in the neutral rotation, neutral flexion, plantigrade position also, when there is high velocity, then it can split the distal pylon or plafond. So pylon, it could be either anteriorly, antermalleolus, we call it, or the postermalleolus, and right in this, when there is a large chunk, more than 25%, it suggests the instability. Like in this picture, we can see the subluxation of the ankle joint. It has moved posteriorly, the distal part, okay, and or the both anterior posterior malleolus. So this distal tibial metaphysis has a large vessel supply, highly vascular. So in the metaphysis, the soft bone, high velocity injury, usually comminuted. So there is a huge fracture, and there are tight fascial structures around the ankle, which may compress. So these areas are also prone to compartment syndrome. So if we do not adequately observe, and we should not, if we didn't let the swelling subside in time. Okay, so these are unstable injuries. We need adequate X-ray. Being this intra-articular fracture, so we may not assess the fracture picture, fracture morphology adequately with the simple X-ray. So we may need to go for the CT scans. Okay, CT scan of the ankle. Say in any intra-articular fracture these days, we say the CT scan is a must. Rudy and Algova has given a classification of the tibial pylon, and type 1 is non-displaced, just the cleavage fracture, undisplaced right here like this, and without any degree of comminution, irrespective. And type 2, it is displaced, like here, more than 2 mm of displacement, we call it displaced fracture. And type 3 is a grossly comminution and displaced. Okay, comminution. Rudy and Algova, it's just simple. Okay, look at this X-ray. It's an X-ray of the child. We can say that it's a child because there is a physis. We can see the appreciate the physis, which has not fused completely. Okay, there is fracture line extending right from here to the joint. So this is the intra-articular fracture. Okay, this has a typical name. This the anterior inferior tibiofibular ligament is attached right over here. With the rotational force, the ligament avulses the distal epiphyseal part. This is the epiphysis, this is the physis, this is the metaphysis, high up diaphysis. Okay, pediatric bone has 4 parts. Okay, epiphysis, physis, metaphysis, diaphysis. This avulsion of the epiphysis. Why this avulses? Because we can see in this part, the physis has started fusion already. It's around 14-15 years child. Okay, the physis has started fusion from the medial leg, but not on the lateral side. So this fused physis is strong enough, it does not give away. But this unfused part, it is a weak joint. So occasionally with the twisting force, the anterior inferior talofibular ligament, it avulses the distal part of the tibia, typically the anterior inferior part of the tibia, and this what we call as Tillaux fracture. Okay, typically in 12 to 14 years old child, and it is Salter-Harris type 3. I think you have already gone through the lecture of the facial injuries. So this is it has from the metaphysis through the physis going into the joint epiphysis. So this is the type 3. Okay, So if it is displaced more than 2 millimeter, we need to fix it. We have to reduce it and stabilize it. Sometimes only reduction is enough, and sometimes we need to go put the hold it with the screw. Okay. Okay, let's see this X-ray. There is widening on the medial side, but lateral side is fair enough. It looks okay. Okay. Sometimes we are provided with this only picture, only this X-ray, and we say this. Okay, there is injury right over here. There is no obvious fracture, and if we don't see any fracture, the emergency people sometimes they say okay, there is no any fracture. It may not need operative treatment, and later on when patient comes to us, when we evaluate, actually the principle of X-ray is inclusion of the two bone, two joint, okay, two view at two times means at the time of injury, and sometimes after 1 week or 10 days. These are the principles of the X-ray. Okay. If the same X-ray, when we do the full length of the leg, we may appreciate the fracture at this high level, the lateral malleus. With the rotational force, the medial deltoid ligament gives away, and sometimes this syndesmosis gives away, and ultimately the fibula fractures high up, which may not be visible in the ankle view only. So the importance of the clinical evaluation, this suggests the importance of the clinical evaluation. Okay. The name of this is a typical Maisonneuve fracture, Maisonneuve, with the external eversion and external rotation. Okay, eversion and external rotation. There is a fracture, sometimes either middle malleus fracture, or there is a disruption of the deltoid ligament with the further rotational force. The syndesmosis gives away, and ultimately the high up fibula right here. Okay. And when this is associated with the dislocation of the ankle joint, like here in this X-ray, there is a gross disruption of the tibiofibular, distal tibiofibular joint, the syndesmosis. So this is typically the Dupuytren's fracture dislocations. Okay, Dupuytren's. Coming to different treatment modalities, there are various options for the fixation. Like here in this picture, putting the two Kirshner's wire, we simply call it K wire. This, which we can see, K wire, or the full name is Kirshner's wire. Okay, and fixing with this stainless steel SS wire, and we make it figure of 8. This we call it modified tension band wiring. This is for the fracture of the medial malleus. Okay, this is the lateral view. And sometimes if the fracture of the middle malleus is a little bit high up in the axilla, we may have adequate space for the screws, the malleolary screws right here. If there is associated fracture of the anterior or posterior malleolus, we may need to put this, like this X-ray. This is the cannulated cancellous screws. Okay, after reduction, or sometimes, sorry, I'm running short of time, we have to hurry. Okay, if there's time is up, then we may log in again. Okay, just 10 minutes more, not more than that. And there is a plating, there is a plate and screw for the lateral malleolus. Okay, same picture right here. This is the typical buttress. When there is supination adduction type of injury, when the middle malleus gets fractures, vertical fractures, we may need to buttress with the plate from the medial side. Okay, this depends on this type of fixation depends on the fracture morphology. This is the syndesmotic screw. From the lateral side, we put it on the medial side. Ideally, this should be horizontal. This has gone a little up, but ideally it should be 3 centimeter above the joint line, horizontal from posterior to anterior, 20 to 30 degree anteriorly. Okay, this is the another picture. This is for the Tillaux fracture, which we have seen. After reduction, it has been fixed by the screw. Okay, so coming to the talus, this is another bone that forms the ankle joint just below the tibial plafond. Coming to the anatomy, it has a head, it has neck, it has body, it has posterior process, and it has a lateral process. Okay, this lateral process sometimes is not visible in the X-ray, so we have to do the CT scan to visualize the X-ray. Sometimes some simple we treat as simple, and depending on seeing the X-ray, we treat as a simple ankle sprain, but the pain and swelling does not subside by 3 weeks of slab or plaster. Then still patient is still having pain and swelling. We should be highly suspicious of the osteochondral fractures around the ankle. This talus fracture is a high energy trauma, high velocity injury. It has no muscle or tendon injury. Okay, 70% of the talus is covered by the cartilage, so the blood supply is very precarious. It has no any muscle attachment to give the blood supply, and almost 2/3 is covered by the cartilage. The fracture is also known as aviator's astragalus. It is the typical mechanism that fractures the talon neck. In ancient times, when the pilot they used to ride the aeroplane, and the radar of the foot radar, when they land it, the forceful dorsiflexion of the foot, with the forceful dorsiflexion, the neck of the talus hits the distal anterior part of the tibia, so there is a fracture of the talus. Because of this typical mechanism, it has been also known as aviator's astragalus. Okay, mechanism: axial loading in the ankle dorsiflexion. So on examination, we have seen there is a huge swelling, bruise around the ankle joint, and the pain with the inspection. There is a huge swelling, tenderness, and palpation, and typically patient unable to bear weight, and then because of the huge swelling, there might be the fracture blisters. Okay, so the X-ray typically we do with the epi, lateral view, and the canal view. And this being the intra-articular fractures, we need to go with the CT scan. Okay, CT scan. This is the picture right here. Sorry. In this X-ray, we can see the lateral process fracture. This is the fracture of the post trigonum. Okay, this is the lateral view. There is a fracture of the it's a more or less of the head or the proximal part of the neck. This is the neck junction. This is the sinus tarsi. This is the neck fracture. This is the fracture of the body of the talus. This is a highly comminuted high velocity body. So talus neck fracture. It has been classified by Hawkins in 4 types. The simple undisplaced fracture that runs through the neck and extends to the subtalar joint, and there is no any displacement, undisplaced. This is a type 1. Okay, when there is displacement, there is displacement at the subtalar joint. When there is incongruency of the subtalar joint, then we call it type 2, displaced type 2. Okay, type 3 is when there is the subtalar joint, the bone has extruded, large displacement. This is type 3. And type 4, disruption of the subtalar as well as talonavicular joint at the both joint. Okay, there is a disruption of the in type 3, disruption of the ankle and subtalar joint, and here in type 4 all 3 joints: ankle joint, subtalar joint, talonavicular joint. Okay, these are the Hawkins classification. Okay, coming to the treatment. If there is dislocation, reduction, it should be emergency, because the dislocated part might hit the nerves and innervations around it. It might lead to compartment syndrome. Short leg slab or clasp for 6 weeks for undisplaced. That is, we call it undisplaced if it is less than 2 millimeter. Typically for the lateral process and the posterior process. Body if it is less than 2 millimeter, and head. Right here, head, if it is less than 2 millimeter, just conservative treatment is okay. For displaced more than 2 millimeter, for typically neck fracture, if it's neck, for displaced, we need to fix it. Okay, for neck fracture, type 1, that is undisplaced, right? This type 1, undisplaced, only slab or cast for 6 weeks, but it should not be non-weight bearing. Okay, non-weight bearing slab or cast, and sometime we may need to check the at 6 weeks we radiologically assess, and if it is signs of union, then we slowly start with partial to full wood bearing gradually. For the type 2, 3, and 4, the displaced fractures, we need open reduction and internal fixation, like here. We need to fix with the screws. So what are the complications? Avascular necrosis, overall 31%. In general, 31%. It also depends on the type of the fractures. So Hawkins type 1, 2, 3, and 4. Okay. In the follow-up X-ray, you can see, appreciate in this X-ray, this is the talar dome. We can see the subchondral radiolucency right here. There is a faint line that has extended from medial to the lateral all throughout. Okay, this sign suggests there is healing process is going on because of the vascularity. The blood vessels has encroached their blood. There is adequate blood supply, and when there is a blood supply, the bone subchondral bone resorption occurs, and this actually is a good sign. It's a good sign. It suggests that the bone is healing, going towards union. This is typically seen in Mortise view at around 6 to 8 weeks. We call it Hawkins sign. Okay, Hawkins classification, Hawkins sign. 2 Hawkins we need to remember in this Talus. And depending upon the different type, there is a different percentage of avascular necrosis that progresses with the type of the fracture. Subtalar and the talonavicular arthritis, malunion, non-union. These are the complications. Okay. So Talus, anatomy, different parts. 70% covered by cartilage, aviator astragalus, the typical mechanism, examination swelling, the typical view. This is the canal view, 15-degree pronated, 75-degree X-ray beam projection, different lateral process, posterior process, neck, body, comminuted. Hawkins, Talus treatment. Okay, if it's undisplaced, slab or cast, displaced, you need to fix with this screw. Complication, avascular necrosis. You should not forget this one. Okay. Actually, these ankle fractures are, though Talus is less common, ankle fractures we commonly see in your clinical posting. So this is a very common fracture we see in our emergency. So you will get to see a lot of cases in this. Okay. The time is, we are running short of time, less than 1 minute. We'll again log in and I will continue this calcaneum fracture. If we are disconnected, then we'll again log in. Okay, and finally we'll summarize in 2 minutes. I won't take more than 5-7 minutes. Okay. Coming to the anatomy of the calcaneum, it has anterior fasciate, middle fasciate, posterior fasciate. This is the superior view. Okay. In the medial view, this is the body. This is the sustentaculum tali. In the lateral view, there is the part that the enter part that communicates.
हेलो सुनिरहेको छ तिमीहरूले यस सर ल भन्दिनु क्यामेरा के भयो
कति जना छ अहिले
आउन बाछ छ अझै भन्दै छ ल न अहिले फेरि भयो
पार्टिसिपेन्ट 52 रहेछ ठिकै छ अहिले 52 देखाछ ए ठिक छ Okay, let's continue with the calcaneum fracture. Okay, the anatomy, as I have already discussed, it is also known as a lover's fracture. And sometimes people they have to jump. They jump from the building, and they sustain this fracture. This is a typical mechanism. They land with the heel, and they sustain this typical fracture. So also sometimes it is also known as a lover's fracture. Mechanism is axial loading and road traffic accident. Sometimes there is a direct hit, direct injury. the associated injury in 10% of the cases because of the axial loading. Because of the axial loading, there are 10% of the cases there is a fracture of the vertebra. Okay, there is fracture of the vertebra. So in 10% of the cases, in all calcaneal fracture, we need to examine the back of the patient. Okay, so sorry. Clinically, there is a huge swelling, and because of the tense swelling, we might have the blisters. These are also two types. This like this one is small blister with a clear fluid transudate, whereas this hemorrhagic blisters, this suggests the deep the level that has given up from the deep level. So this there's a vascular supply also disruption. So these are likely to be infected. Even we operate in these hemorrhagic blisters, they tend to get the infection. So we let the swelling subside till the wrinkle sign comes. After around 2 weeks, sorry, the ankle swelling gets subsided and the wrinkles will come. Then only we take up for the operative management if we have to operate. So we have to be very careful about the compartment syndrome, because this is a very tight compartment. Sorry, swelling, compartment syndrome, there is a risk, and open wound in around 17% of the cases, especially associated with the road traffic accidents. So what are the X-rays? Typical X-ray we see is the AP and lateral view, the Broden view, Harris axial view. These are the typical. Okay. In lateral view, see, in AP it's not much clear for the calcaneum. It's the lateral, Broden, and Harris axial. I forgot to put the Harris axial view here. This is the lateral view. It's of the most important, in which we assess the calcaneum height. Okay, this is there are angles we need to measure in this. This angle of Gishen, this the blue line. This is the angle of Gishen. This subtended by the posterior articular fasciate of the calcaneum and the anterior. Okay, normal is 130 to 145 degree. Usually when the height decreases, this flattens, it increases, and sometimes it becomes negative beyond 180 degree. When this height goes up to this level, this is negative. Okay, and the bowler angle we measure it from the these two lines separated from the posterior process to the superior margin of the posterior fasciate and the superior margin of the enter part of the body, enter process. Okay, so this line, this red line, the angle subtended is the bowler's angle. It's a 20 to 40 degree, and this also when it goes below, when this apex depress is when there is intra-articular fractures with the joint depression type, this lowers and it flattens, and slowly it may end up in negative bowler angle also. Okay, like in this case, we cannot see this posterior part of the posterior fasciate, right? It has gone way down, so this negative bowler's angle. Sorry. Broden and Harris axial view. Okay, Broden view is also is a AP view with the ankle slowly rotating in the 10, 20, 30, and 40 degree. We assess this, the fracture line that runs in the posterior posterior fasciate, posterior articular fasciate. To visualize this area, we need to do the Broden view and the Harris axial view. In the Harris axial view, we assess the congruency of the posterior articular fasciate. And it is a must. CT scan is a must for the proper assessment, evaluation of the ankle joint, and this calcaneum fracture. So because when there's a high velocity injury, axial loading, there's this calcaneum being the metaphyseous, most of the cancellous bone, and huge combination we usually see in this type of fractures. So we need to do the CT scan to properly evaluate the fracture morphology. Right here, the fracture is comminuted, joint depressed type. There is a broadening of the heel. Right here, see, broadening of the heel. This is the typical tongue type. Okay, we'll come to this again. There's a tongue type, and there is a posterior, the secondary fracture line extends from the posterior fascia towards the this calcaneal tuberosity. The sorry, classification. Coming to the classification, it has been classified as the extra-articular when there is a simple bony avulsion or simple extra-articular fracture, marginal fractures, or sometimes cut injury, open fractures. These are the extra-articular sustendiculum tali and posterior calcaneal tuberosity fractures. These are the extra-articular fractures. The other is the intra-articular fracture. Intra-articular fracture, the Essex Lopresti has classified in two types: a joint depression type and tongue type. This depending upon the secondary fracture line where it exits. Okay, when this secondary fracture line exits below the super margin of the posterior articular fasciate, below this blue line, this is the joint depression type, and when it exits way posteriorly, it is the tongue type. Okay. Based on the CT scan, Sanders has classified into various classification into type 1 to type 4 with the type 1, 2, A, B, C, 3, A, B, A, C, and 3, B, C based on the fracture morphology. It has classified, divided the posterior fasciate. This is the posterior fasciate of the calcaneum into A, B, C with the 3 different lines. And the medial, this is the sustendiculum, and this is the medial, intermediate, and lateral column. Okay, based on the fracture pattern, where is the fracture, location of the fracture. It has, Sanders has given the classification. It's a bit complicated and not required at this level. Treatment goal, the aim of the treatment of the calcaneal fracture is restore the calcaneal height, restore the length, width, and the alignment. Okay. If it is undisplaced, non-weight bearing slab cast for 6 weeks, then slowly then a partial to full weight bearing. Sometimes we may need to wait for up to 12 weeks, 3 months if there is a joint involved. Then we may need up to 12 weeks. So this 6 to 8 or 12 weeks, depending on if it's extra articular, we may make weight bearing in 6 weeks. If it is displaced, like here, this if it is displaced, there is a depression. The height is calcaneal height is lost, so we may need to lever it up and fix it with the screws, or sometimes like wires, K wires, or Steinman pin, either enclosed. This we call it Essex Lopresti maneuver, or this is simply the close reduction and percutaneous pinning, CRPP we call it. Okay, close reduction, we reduce it closely without opening under the C-arm image, and fix it percutaneously with the screws or wires. And this typical maneuver levering is called Essex Lopresti maneuver. Okay, and sometimes we open it and fix it with the screws and plate. When there is a grossly combination, there is a articular incongruency, and we feel like patient cannot bear even after the 12 weeks because of the pain. Then occasionally, this though very rarely done in the young patients, especially because these calcaneal fracture they are seen in the young patient, unlike in other elderly. So do this less commonly done procedure, primary arthrodesis. It is also an option. So what are the complications of calcaneal fracture? Most and foremost is a wound complication. We always, as orthopedic surgeon, we fear about it to take up to the OR operating room for the operative fixation. We fear about the wound complication, which is commonly seen in 10 to 25% of the cases due to the broadening of the heel. Okay. So due to the broadening of the heel, there might be impingement of the tendons around, and typically the peroneal tendons are at risk. The peroneal tendon impingement, the sural nerve when it gets hit, there might be neuroma. The flexor hallucis longus tendon injury, FHL, flexor hallucis longus, and we should be very cautious to observe for the compartment syndrome. It's the calcaneal compartment is one of the compartment in the foot. Okay, so we have to very vigilant about the monitoring of the compartment syndrome. When there is huge swelling and the swelling itself compresses the nerves and vessels that supplies the bone and soft tissue around, there is a microvascular compromise because of the swelling. So that leads to the compartment syndrome. Patient presenting with severe pain out of proportion, and with the passive movement, a stretching of the toes, if there is a pain, and then we see ideal is to monitor the compartment pressure, which we rarely do over here. We have to be quite vigilant about the compartment syndrome, which is seen in 10% of the cases, and that leads to clawing of the tooth. When there is a fibrosis of the, because of the compartment, the microvascular compromise, there is no loss of vascularity in the muscles, and the flexor digitorum brevis muscle gets avascular, then there's fibrosis, then that leads to the clawing of the toes. Okay, and when there's a malunion, when the displaced fracture, it heals of itself, there's a malunion, and the most common complication is the subtalar arthritis, because of the when there is the articular cartilage is injured, our body cannot itself form the hyaline cartilage. It heals by fibrocartilage. Okay, the healing the articular cartilage is heals by the fibrocartilage, which might be painful. So when patient with beards, the way at the fracture site later on, even though it gets healed, is patient is likely to have subtalar arthritis, and ultimately we may need to fuse the joint, that we call arthrodesis. Okay, ultimately the patient may need arthrodesis. So these are the complications which you should not, you cannot forget and to write if it comes in the exam. Okay, only complication: cranial nerve impingement, shoulder nerve neuroma, compartment syndrome, malunion, subtalar arthritis. So the basic rules: proper history, mechanism of injury, adequate examination, scan. In orthopedics we call span, scan, and scan. Sorry, I forgot one. Span, scan, and I forgot the third one. Next class I will take. And rise. Okay, rise, rest, immobilize, compression, elevation. Okay, rest, ice, compression, elevation. Surgery only when the swelling subsides. Okay, thank you for the listening. Okay, let's summarize. Very short. Okay, very short. Okay, ankle stabilizers: deltoid ligament, lateral collateral ligament. 3-part: the syndesmosis, high ankle sprain, clinical picture, Ottawa ankle rules, X-ray views, AP, Mortise view, lateral view. Okay, these are the ankle series, ankle trauma series. Like in other case, in trauma we call it trauma series for the C-spine lateral view, chest, and pelvis. These are the trauma series. Okay, stable, unstable, Lauge-Hansen classification, Dennis Weber, ABC. This you should not forget. These are the typical case series which we have discussed. Tibial pylon fracture, Rudy Algover classification, Tillaux fractures. You see, Tillaux fracture. This Maisonneuve injury. At the ankle, you see one small fracture, and high up there is lateral. So you should always palpate the whole length of the fibula to not to miss the Maisonneuve fracture. Okay, different treatment modalities: fracture of the talus, typical mechanism in dorsiflex foot, axial loading, the precarious blood supply, different parts. In examination, huge swelling, Hawkins classification 1, 2, 3, 4. Talus fracture, it's the management. Undisplaced, less than 2 millimeters, slab is enough. For displaced, you need operative management. Complication, you cannot forget a vascular necrosis. Okay, it depends in increases with each degree of displacement. Hawkins from Hawkins 1 to 4. Hawkins sign, the subchondral radiolucency, you cannot forget this one. Calcaneum is the mechanism, axial loading, the huge swelling, compartment syndrome. And in calcaneum, always examine the vertebra position in 10% of the cases. The typical X-ray view, lateral, the Bowler angle and angle of Duchenne, CT scan, classification, extraarticular, intraarticular, sexualopresty, joint depression type, tongue type. Okay, Sanders has given CT-based classification. Treatment on displaced slab cast for around 6 weeks to 12 weeks, and displaced sexualopresty, or if with plate and screw, and occasional, very rarely, primary arthrodesis. Complications, wound, tendon and nerve impingement, compartment syndrome, very careful, we need to be malunion, and subtalar arthritis.